Good afternoon. This is American Surgery Center and CHRIAS, our Bariatric Friday event. Today is July 8th, 2022, Friday, as you mentioned. So welcome to our event, our episode. We are going to discuss another topic with Dr. Irgau. Dr. Irgau, how are you doing?
I'm doing great, Kemal. How are you?
Good, good. So we had a little bit break with a couple of our time offs. And then Samantha and Katrina are going through their process, and they are getting a little bit impatient with what resolutions they are going to see from the process that they are going through. They are going to have the surgery, and they are getting close. And as part of our process, we explain what comorbidities, which are the illnesses related to or originated from morbid obesity. I may refer to as comorbid versus the other illnesses when we are discussing this. So the resolution of these, because as we mentioned for several times with our different sessions and topics, the way that we have we look at the morbid obesity is if it's like a single episode or single isolated issue, but it's not. I use issues specifically because there's still some people who are not understanding this chronic illness, morbid obesity, and actually it's the root of many problems that we are having, and it always comes with siblings like cardiovascular issues, diabetes, the reflux, sleep apnea, and all these problems, as they are not being addressed properly, then they have their other siblings, and then it becomes a big health crisis. So today we are going to discuss the resolution of comorbidities, and Dr. Irgau, you are going to educate us so then we can have a good understanding of what we would expect from this surgery.
Thank you, Kemal. Let me just reintroduce myself again. As you said, we did have a little bit of a hiatus. My name is Dr. Irgau. I'm the president of CHRIAS, or Christiana Institute of Advanced Surgery, and my specialty is bariatric surgery or weight loss surgery. And I have been performing weight loss surgery now for 20 years. And with my associates at CHRIAS, we're by far the most experienced surgical practice when it comes to bariatric surgery. And as Kemal mentioned today, we're going to talk about the fact that bariatric surgery is not just about weight loss. It is far more important than that. In fact, bariatric surgery is about improvement of health overall. And as Kemal mentioned, there are a number of illnesses that go hand in hand with obesity. And as obesity is taken away, as the weight loss happens, so do those medical problems as well. That is why so many doctors are actually big fans of bariatric surgery nowadays, because instead of having to treat different illnesses like diabetes, high blood pressure, sleep apnea separately with different medications, they can refer their morbidly obese patients to bariatric surgery, and with adequate weight loss, there will be a resolution or improvement of all these conditions with one single treatment, bariatric surgery.
So in some episodes, we do repeat ourselves, but because we do have, well, people don't listen, number one. So this is from the prior session that I have. So then we are trying to explain certain things, and like sometimes we don't hear if we don't pay attention. If it's not interested, if it has nothing to do with our lives, we don't pay attention. We look at the headlines, and we have this solution, right, Dr. Irgau? So, and it's not used. So, and when it's used, it's still being kind of like there's still the stigma, and then there's still this pressure, and it's only 1% of the patients who are qualified for the surgery is choosing the surgery for curing the problem. So that's one of the biggest problems that we probably have in healthcare. So I'm going to probably repeat, or if you want to repeat what I'm saying is that 1% of the patients who are qualified, I say qualified, but who should be getting the surgery is getting the surgery. 99% of these people with BMI 47, now our ladies, let's just maybe, you're right, so it's after 2 weeks, even I forgot what I was doing. So these two ladies with their BMI, these are real. I mean, the names are not real, but patients are real. These people are living with, and they're the lucky group because they decided to go through the process. But the 99% of people who may be in the same situation choosing not to do anything with the actual cure of the problem, so the curing the problem. So that's I think it's very sad. So I think more people should really understand. And one of our reasons that we are doing this, we can reach out to more people, we can educate more people. But even after, Dr. I was out and in a different maybe domain, in a different country, they are worse than we are in terms of the stigma itself. Yep. I mean, if you're in Turkey, someone is just going to tell your face that you are. They will drop the F bomb, not that 4-letter F bomb, but the 3-letter F bomb, and because then just imagine how you would feel. Like we are still better here, but better is 99% is not getting the care. Yeah. That's horrible. So, but let's focus on, this is Samantha and Katrina's show. So let's look at the resolutions again. Now, Dr. Before you start, I just want to give these 4 numbers. So, and I did mention these in our other sessions, other episodes, but patients with diabetes, in the case Samantha has diabetes, 83% of the patients, if they follow through our guidelines and follow through with the program, 83% of patients, they will who have diabetes, they will actually no longer have diabetes, and this is 83%. This means they may be taking 1, 2, or 3 medications to manage diabetes and no longer taking pills for that. 82% of the patients with vascular disease will be resolved, and the reflux is anywhere from 72 to 98%. And the sleep apnea is 74 to 98% will be resolved. So this is kind of interesting when I see the treatment options for sleep apnea, and then like from our training, the first thing that I do is look at the BMI, but then they're actually trying to treat the sleep apnea on a patient with 47 BMI, but then there's no morbid obesity treatment. So that's one of the, again, reason that I'm saying that these disease itself, when they are not being treated, it just is a snowball. So all these problems will be resolved for those patients who may go through the process and then follow the process. So this is huge. And yet we have very little group of people who are choosing to go through this. So tell us about the resolutions and how that actually happens.
Absolutely. So, Kemal, you just mentioned an extraordinary fact, and that is up to 85% of people who have type 2 diabetes and morbid obesity and undergo bariatric surgery actually will see improvement or resolution of their type 2 diabetes. In other words, you've just stated that bariatric surgery is a treatment for type 2 diabetes. And doctors have accepted this fact right now. When you talk about treatment of type 2 diabetes, bariatric surgery is mentioned as an important method for treating type 2 diabetes. And what is the reason for that? Well, the reason is very simple. And that is because type 2 diabetes, in the vast majority of cases, in over 90% of cases, is actually related to obesity. As it happens, the mechanisms that lead to obesity and the mechanisms that lead to type 2 diabetes are very closely related, right? The weight goes up, blood sugar control goes down, right? The blood sugar raises, and the person becomes pre-diabetic, and then they become diabetic, and then they get medications for it. Mm-hmm. Well, guess what? Type 2 diabetes, although it's different from type 1 diabetes, it's still a very devastating disease, right? Type 2 diabetes is a progressive disease that can lead to heart disease, that can lead to cardiovascular problems, that can lead to kidney failure, that can lead to blindness, and it's a progressive disease, which means that over time it gets worse and its effects on the body are devastating, right? So we are saying that if you have obesity and type 2 diabetes, the chances of treatment of type 2 diabetes are going to be closely correlated to your chances of getting rid of the obesity or of the weight. And bariatric surgery does precisely that. So really showing the effect of bariatric surgery on type 2 diabetes, we can really illustrate how bariatric surgery gets to a much improved health profile in a person, right? As it happens, there are other conditions closely correlated to obesity. As you mentioned, there is high blood pressure, there is heart disease, there is sleep apnea, there is problems of joint disease, other gastrointestinal problems, problems of urinary incontinence, particularly in women, problems of infertility in women, right? All those are closely correlated to the weight. The higher the weight, the worse these conditions are. So when we tackle the weight with bariatric surgery, we are able also to tackle all these problems of health that the person has. So when we talk about comorbidities, we're talking about health problems that go hand in hand with obesity. Now, one thing that we know very clearly is that once obesity reaches a certain level, it's almost impossible for any person to lose the weight just by themselves with traditional diets and other approaches, right? So if the body mass index is greater than 35, greater than 40, a person who is told to go and try to lose the weight by themselves, they will find out year after year that whatever diet they try, they will not be able to tackle that problem. And it has very little to do with the willpower of the person, or it's not that they're doing the wrong diet, it's that the problem is very, very difficult to solve. And at this stage, bariatric surgery is the most effective treatment that we have available. So when we talk about bariatric surgery, we're talking not only about helping the person to lose weight and, of course, improve their quality of life, but also importantly, help them tackle these very important health problems.
So, again, between the two case conferences that we held with the Accountable Care Organization and the Surgery Center, there are two isolated case conferences. The nurses are different nurses. The only common element is me from our point. I just want to tell you this. I think we shared this last night in the providers meeting. As I was explaining the situation, and one of the patients we highlighted, not from the bariatric reason, it was for the joint problem. They have a chronic low back pain. And Sean actually was the one who highlighted, like, well, they're trying to fix this problem, but patient BMI is 50. So patient also doesn't understand that. In some cases, again, I'm just mentioning this gently. I think our other clinicians in United States, they need to also have a better understanding of the root cause analysis. What is causing the chronic back pain when I'm 210 pounds? So, and if I'm 350 pounds, I have extra 140 that I'm actually carrying. Well, my joints are not going to be so happy after a certain time. And my back probably is not going to be so happy. And everything in my life is going to change. But when I see, again, patients should be more knowledgeable. Other clinicians should be more proactive when the BMI is 50, then how can I treat this patient just for chronic care? I mean, chronic low back pain. So now, related to that, and that was when I mean, as you know, I look at the data and there has to be enough of it. So it can't be just 3 or 4 patients. And because I'm not a clinician, so I look at the data from a different perspective, how many times certain things are happening in the same situation. And I see patients with uncontrolled diabetes, they have depression and they have depression-related medications that they are taking. And I'm like, oh, there must be some link with the uncontrolled diabetes and depression. And when I asked Dr. Handal, he's like, well, come on, like, we knew that. Like, well, I said, I didn't know. So, and then he said, why do you need to know? Because I said, my mom has diabetes. And if that's not controlled, then she needs to know as a patient that her depression is going to be, there will be depression-related issues, right? So there will be migraine-related issues coming from the, like we are talking about diabetes, so let's just say that for a second. So diabetes with the depression, there's a direct link, uncontrolled diabetes. So anxiety, there's a direct link, again, with the uncontrolled one. So when what we see commonly is the diabetes, the vascular disease, reflux, sleep apnea, but depression and migraine. This is like depression at 55%, migraine is at 57% result when patient is losing the weight that they should be losing after the surgery. Can you actually just elaborate that a little bit, like how the behavioral health plays a factor in this and with the resolutions?
Absolutely. So let's look at those conditions, both of them. Kemal, you mentioned migraines and you mentioned depression. Okay, very important, and we see them very often associated with obesity. Clearly, it is no surprise that a person who is struggling with obesity also struggles with depression. Why? Because obesity itself leads to lowered self-esteem. Obesity itself is clearly one of the conditions that still is stigmatized in our society, right? And that lowered self-esteem, that inability to really fully participate in your, with your full capacity and with those surrounding in your own community, that leads to depression, right? That leads to hopelessness, particularly when you're trying so hard to lose the weight and all you see year after year is the weight going up. So it's not surprising that there is a very high rate of depression among people who struggle with obesity. And no surprising, when people have bariatric surgery and lose the weight, the sense of self-esteem increases, the sense of hopefulness about their future improves. So you see improvement as well. But look at the flip side of that situation, Kemal. If you're struggling with depression and you have morbid obesity and all you're getting are antidepressant medications, guess what? Many of those medications actually are going to increase your weight. They're going to increase appetite. So people who are taking those medications also see that their risk of weight increase is actually much higher in that situation, right? So there is no question that, particularly with people who struggle for a long period of time, we see a high rate of depression, and there is clear improvement once the weight loss occurs. And let's look at migraine. There is actually a specific type of a condition that leads to headache, which is known as pseudomotor cerebri, right? That is a condition where there is an increased pressure inside the head of the person, inside of their the intracranial pressure inside of their cranium, right? Actually, in this situation, when the person is also obese, by far the most effective treatment is bariatric surgery. And no surprise, we do get referrals from neurosurgeons for patients who are morbidly obese for us to do the surgery, reduce the weight, and therefore get rid of the headache that these people suffer from following the pseudomotor cerebri. So just two examples of how morbid obesity leads to more health problems, and resolution of the morbid obesity clearly leads to improvement in those health conditions as well.
So thank you, Dr. Gao, for that. Now, the other vascular disease, is it venous status disease? So that's
Absolutely.
95%.
Absolutely.
So that's related to heart, although it's on the legs, but that's right. That's
Yes, the inability for the venous circulation to flow freely because there is so much pressure on the upper portion of the body. So you've got what's called stasis. The blood doesn't flow very well, and people are at higher risk for blood clots. They are higher risk for things called varicosities in their legs, and they are at higher risk for something called lymphedema or swelling of their legs as well. And we see much more improvement again with adequate weight loss as well. And that by itself can lead to many skin problems, for instance, wounds that are difficult to heal in the legs, and particularly when patients happen to be diabetic as well, that risk of non-healing wounds is even much, much higher.
So, Dr. I did bring this slide up again. This was from why the patient dropped the program, but it becomes more meaningful when I know the resolution. We are talking about like some big numbers, right? So number one, like 95% of the patients do have a positive outcome on their quality of life. 83% reduction in 5-year mortality, which we live longer. I'm just thinking, and I don't want to be distracted, but for Buddy to live for another 2 years, what would I not give up, or what would I give up? This is big, right? So if we think about, if let's say we don't care about ourselves, but if it's our loved ones, what would I do for one of my family members to benefit from this if they have this problem is huge. And yet we still have people who are kind of dropping out and not benefiting from it. We can only do so many surgeries a day. So it's not about us trying to do more surgeries. We are busy enough. So this is really just making people aware of, like, they should be getting surgery somewhere else. That's fine, as long as they find this as their solution for their overall health. But yet we have a lot of people, like, what do you think we can do to actually make this message clearer to these people, and to again, I'm going to always include the clinicians, because and I know you won't say this, but I will, but I do want our physicians, our clinicians, anywhere, like not just here, but anywhere. You guys are clinicians, and you have a different responsibility. Patient and physician relationship is not equal. I go to that exam room for what I don't know, and then you are the licensed person to tell me. So you cannot tell me that you were embarrassed. You don't want to embarrass me, so that's why you didn't take care of my morbid obesity. You can't. You don't have that luxury, right? So that's why I will always include them in this. So because when patients hear these from their physicians, then from their primary care, from their specialists, then they have a different perspective of the issue. It becomes a perspective rather than perception. So we have to be able to reach out to more people and fix this issue, because we are not getting healthier. More people are morbidly obese. Delaware is number 2 or number 3 in the States. So this is a big issue. Now, again, why would patient not choose this route is it's something that we need to be able to kind of address a little bit more, I don't know, maybe harsher.
Yeah. Well, come on. The simple answer to that is we have to continue to do what we're doing, right? These outreach sessions that we're doing right here are really designed for us to pass on this important message to our community. And it's working, right? People are watching this and they are understanding it. And it may not be for them, but it may be for their loved ones, right? But let's pick on two issues that you have raised, Kemal. First of all, one is the issue of whether the weight of the patient should be a discussion point when the doctor and the patient come together to talk about the patient's health. The other issue is the reduction in risk of death that bariatric surgery can bring. Mm-hmm. Okay, let me tackle the first issue by just giving you an example. I saw a patient this week in the office who came to see me because they had a mass on their back, right? There is this little swelling that they have. It is most likely something called a lipoma, which is like a little ball of fat that accumulates underneath the skin. It is something that requires a relatively minor procedure, right? The patient will have a small incision and the lesion will be removed, right? But the patient that's coming to see me happens to have a body mass index greater than 50, right? Which means that at least they're about 150, if not more pounds over their ideal body weight, right? Now, this lesion, Kemal, is on their back. And for me to be able to do the surgery on this person, that person will have to lie on their tummy, right? You can imagine that on the table. Now, if we are going to give sedation to this person, if they're going to give them something to make them sleepy during the procedure, because of their weight, because of their airway, they are in grave danger of having serious problems related to anesthesia, right? So I was discussing with this patient that the best way to do this surgery would be to do it with them awake under local anesthesia, where we numb that whole area, right? And they will be in full control. So just doing this minor procedure could actually put this person in a life-threatening condition because of the obesity. So how can we not discuss their weight issue in this situation? We have to. So my next question with her was, what are you doing about your weight? What steps are you taking? And I was happy to hear that she's actually discussed this with her doctor, and she has been doing relatively well and has been losing steadily weight. So it is central in her mind, in her health, and she knows that. So whatever the complaint the patient is coming to us with, right? If they have morbid obesity, we are bound to discuss that as well, because morbid obesity affects so many facets of their health, right? Now, to go on to the other issue of the risk of reduction of risk of death, let's take the leading causes of death in our country, Kemal. Cardiovascular disease, right? Diabetes and cancers. These are the three leading causes of death. And guess what? All three of them are actually related to obesity, right? Cardiovascular disease, diabetes, as well as cancers. We haven't mentioned cancers in our talk today, but there are actually many cancers in men and women that are directly related to obesity. So when we do bariatric surgery and reduce the weight of the person, we're actually having an impact on their mortality as well. They are likely to live longer because they are dodging these major causes of death: diabetes, cardiovascular disease, and cancer, right? So when it is placed, when we put the discussion in such stark manner, obviously people are going to understand. But there is the other side of the story that it is imperative we explain, and that is, what are the risks of bariatric surgery, right? People still may have this notion of bariatric surgery as something so dangerous that it should be done only in extreme cases. Far from it. The way we have developed bariatric surgery right now, the risks are actually comparable to many other common procedures like hip replacement surgery, gallbladder surgery. So we have to be able to educate also our community and all other healthcare providers that we have really met very high standards of safety in bariatric surgery. So when we try to present the risks of bariatric surgery with the risks of staying morbidly obese, the patient is actually way better off having bariatric surgery than not.
So I guess in this slide, the cancer is mentioned there, and that was one of we started including that in the last couple of cycles of this. Now, any specific type of cancer or is it any type of cancer?
No, there are specific. For instance, in men, definitely prostate cancer, definitely colon cancer are, affected by obesity. In women, breast cancer, endometrial cancer are affected by obesity as well, closely related to obesity. So the higher the weight of a person, the more chances that they may have these cancers. And interestingly, Kemal, when obesity is present, these cancers tend to happen at a much younger age as well. So a young person is not protected by their youth against cancer if they have obesity, right? That's another very important implication that obviously we have to pass on.
So again, for us, we know this and we want to share this. So that's kind of like our bottom line, and that's why we are here every week. I wish that there is a more efficient or more broader way to actually reach out to more people. But again, when we deal with perception, it's so difficult to change certain people's opinion. And I always tell them, look, put one of your family members in the situation and then talk to me. Some very minor, it may look so minor to you, may not be minor to the person that you really love. Like, that's kind of like, if you don't care about the other person, like you're not going to worry about what they're going through. But if you want to spend more time with your loved ones, then you want them to be taken care of. And you want them to take care of themselves, but also taken care of. And then best option being available to them. Now, you mentioned the risk. The risk is like the gallbladder. Well, actually, our risk even in fact lower than the gallbladder, because if it's done in the hospital, then you have to stay overnight. When it's done at the surgery center, in our surgery center, 99% of the patients are being discharged 8 hours after their operation. Now, so when I share this with when I was in Turkey with one of my, I won't mention the name anymore because they are watching it apparently. So, my brother-in-law was shocked that we were discharging people. So I didn't give the name. I said brother-in-law, right? So that's, so I'm like, why are you shocked? I'm like, why would you be shocked with this? Because they're like, that's a huge surgery. And I'm like, no, that's not the huge surgery. It's just the way that we operate. We prepare our patients. We prepare ourselves. This is not something happening overnight.
Yeah.
Like that part is like, then when I explain it, he's like, okay, now I see your point, but what if he never asked that question, or what if I never had that discussion with him? And he's not someone who's going to be benefiting from this. He's a relatively skinny person. So, but not understanding the risk of what the comparison of like what's this surgery versus appendix or gallbladder. And gallbladder can kill you if it's done in the emergency setting and if it's late. But this has a 3 to 6 months process that we are going through to prep you with several different clearances that you are going through, and for the best outcome for Samantha and Katrina. So I don't want to steal the show from them, but they are going to benefit from this. Like definitely, Samantha is not going to have her diabetes medication 6 months or maybe 9 months after the procedure. The same thing with Katrina. So she's not going to have her depression issue because she's not able to go out and date. She feels insecure about her body, but this is not about how you feel about, like, this is not about the look, but it's about the health. But in this case, it both works. So why would she not want to benefit from this? She's only 37. Yeah. She's still 37, maybe 38. So, but this is all good, Dr. Erkan. Anything that you would like to add?
Yeah, absolutely. So essentially, as we say, one of the things that very often we see when patients come for consultation for bariatric surgery, and we ask them, I ask them, how long have you struggled with weight? The first thing they talk about is how incapable they have been themselves in dealing with this, as if this is an issue of simple willpower, right? People feel guilty that they have to come for bariatric surgery, that they have not been able to do it by themselves. And an important message that we have to pass on is that really the problem is far deeper than willpower. It has biologic roots. It has intrinsic biological mechanisms that are driving the body into a higher weight, obviously in the right environment, in an environment where there is availability of cheap calories, an environment where there is really less opportunity for being physically active. That's where obesity flourishes. But it is here, regardless of how the environment is affecting us, our own biology is favoring that. And we all know that. We all know, for instance, Kemal, how hard it is to lose 10, 15 pounds, and how easy it is to regain those 10, 15 pounds in a matter of a weekend, right? And that is because the body favors that higher weight for a number of reasons. So it is very important that patients come out from this sense of guilt and really face after the fact that they have a chronic illness that is really leading them to even worse chronic problems like type 2 diabetes, like hypertension, heart diseases, and cancers. And they have to understand that bariatric surgery is a very important treatment that is available for them.
One last note, Dr. Erkan, one of our patients, we know who the patient is very well. If I have to give you one of my highlights this week, what made me so happy to see her getting her surgery. At her record right now. So this is almost 9 months. But she wasn't going through that 9 months because of the length of the process. It's just because she had her ups and downs in her life, losing loved ones and going through the depression and healing from that process. And we never give up on her. And she had her surgery this Wednesday, 2 days ago. This is the feeling is amazing. I can tell you that. And we even talk about her today because she's not on the list for the outstanding patients. But that also tells you how much we put, how much effort we put. I know everything about that patient, and we could have easily closed her case. I mean, in fact, we sent her a couple final notes saying that, look, okay. And then you said, no, I want to see that patient one more time, Kemal. I'm like, Dr. Erkan, she's going through a lot of trouble. And then I'm on board, and then our nutritionist comes in and says, like, I need 2 more nutrition classes for it. People, this person needs help. And then when I saw her complete it, that's one of the best highlights of my week. So it's extremely rewarding.
Absolutely.
And we want to be able to help more people. That's all we're trying to do. And hopefully we can, and we'll be back next Friday. We're off, right? So,
no, next Friday we're okay.
Okay, so
the following Friday we're okay.
Yeah, we'll be back next Friday with Samantha and Katrina journey. And until then, please stay safe and have a nice